A very good evening to all of you. Today, March 3rd, is observed as World Birth Defect Day. And on behalf of Society of Fetal Medicine, I welcome you to the day that we observe from society to bring awareness in the society about what the importance of having Birth Defect Day is. So every journey matters is the theme of 2025 on this World Birth Defect Day. And you'll be surprised to know that every year about 8 million children are born with birth defects, which is definitely a phenomenal number. And it just takes 8 seconds to raise awareness for the children affected by birth defect. It's every journey that matters, and there's awareness that we need to increase without stigma to these children. Across the world, societies are working today to bring awareness on this particular World Birth Defect Day, including our society, and it's a commendable job done by all. The most important thing is that every journey that matters, the focus is on the diversity of experiences, and we need to consider the peculiarities of each case. The WHO wants to focus on the results and resilience, and they want to invest in women, girls, adolescents, and these vulnerable children. And that is what is most important. Society of Fetal Medicine believes in taking everyone together. And that is why we want to observe all these days which make a social impact on our society. I would request Dr. Mohit Shah to take it forward from here.
Good evening, everyone, and welcome to this World Birth Defects Day. I want to thank Dr. Rima personally. Well said, well put, and I really appreciate what you have done today, getting all of them together. We are a large country with a huge population. With it comes the obviously statistical law of averages. You have higher rate of birth defects. In spite of the awareness, in spite of technological advancements, in spite of the increase in knowledge and awareness, we still have kids born with defects. Kids, the idea is to detect them prenatally so that we can give them a chance to work up and give a choice to the parents. So with this concept, what I'm proud today is again the enthusiasm of younger members to come forward and present their cases on the national stage. I'm extremely proud, not one, not two, but 10 new people will be presenting their cases and interesting ones. I'm eagerly looking to see the images and hear them out because each one of them will have some unique point that I think everybody can take home. So with this, I'm proud to announce the first speaker. He is Dr. Pramod Bafna. He's a keen and enthusiastic radiologist from Devas, Indore, near Indore, MP. And he's going to talk on arthrogryposis, an interesting dilemma. Over to you, Dr. Pramod.
You can start presenting, Dr. Pramod. We can see your screen. To unmute yourself.
Yes, ma'am. Am I audible now?
Yes, please start.
I'm going to present an interesting case of arthrogryposis.
Go on, Pramod.
Yeah. My patient is Mrs. M. She's 27 years old, and she came to me for a targeted scan. The first trimester USG was not done. She has a very bad obstetric history. She is gravida 7, parity 2, with 4 abortions. And of the 2 living females she has, one of the females has a subnormal intelligence. And the interesting thing was that the features which I saw in this current pregnancy were similar to the features which she had when she had the first pregnancy. I'll come over to those features. On ultrasound, this fetus, what we found was a single life fetus. The fetus was relatively small for dates. The fetus shows extended lower limbs, inability to flex the limbs. There was club feet. There were contractures at the wrist and elbow. There were clenched fists. One orbit was smaller than the other. There was micrognathia and a flat face. These are my ultrasound images. These are showing the club feet deformity over here. The limbs remained extended throughout the scan. The upper limbs were flexed with somewhat clenched fists, and one orbit was smaller than the other. So we came to a conclusion of arthrogryposis, and we were left with either option to terminate this pregnancy and everything would go away, or was to evaluate the fetus and or to do an amniocentesis and a whole exome sequencing on this fetus and to do a complete fetal evaluation. We opted for amniocentesis with whole exome sequencing and evaluation of the fetus. These are the post-abortal pictures, which shows the extended lower limbs, the flexion deformities at the elbow, at the wrist joints, with a flat face, large philtrum. And these are the radiographs. We then sent out over this fetus to an expert for fetal autopsy, as we know that arthrogryposis is not a specific diagnosis, but a clinical finding in about 300 disorders. So when the autopsy was performed by an expert, he could pick up these axillary pterygium. These are bands extending from in the axillary region. They could pick up a pterygium in the area of the hip. The genitalia was somewhat hypoplastic. It was resembling like a male penis, but was very small. The face was flat with a micrognathia, a large philtrum. They also found on autopsy there was a right lung hypoplasia and a right-sided cardiomegaly. This is the autopsy report showing a large head, facial dysmorphism, height, pelvis, short neck, bilateral clenching of fist, abnormal joint contractures, right pulmonary hypoplasia, and some findings resembling cardiomyopathy. And the fetus on ultrasound was around 19 weeks, but clinically and was resembling 17 weeks as per the autopsy. And on the basis of this, they reported it as a fetal akinesia deformation, multiple pterygium syndrome, and possibility of a neuromuscular disorder. So what we did was we did a whole exome sequencing on this fetus. And what we found was that the zygosity was heterozygous. And there was a RIPK4 mutation at exon 5 level, exon 7 level, and also at exon 281 that in the TTN gene responsible for congenital myopathy and cardiomyopathy. But to our surprise, I'll tell you that Bartsocas-Papas syndrome associated with RIPK4 mutation is a homozygous condition and has an autosomal recessive. But according to this, it could not manifest in this manner. So we are left with the conclusion, are we dealing with something that is a compound heterozygous? So what we decided was we decided to do a whole exome sequencing on both the parents. Just a brief word about Bartsocas-Papas syndrome is a rare disorder, and the classical thing is a popliteal pterygium. In this case, we could not pick up any popliteal pterygium. So what we did was we did a whole exome sequencing on the parents, but to our utmost surprise, none of the genes was seen in the father of the fetus, and all the 3 genes were present in a heterozygous state in the mother. So as we know that Bartsocas-Papas syndrome and even the arthrogryposis multiple pterygium syndrome has an autosomal recessive mode of inheritance. So considering our case, there was no genotypic or phenotypic matchup of this case. I went through the literature and I found that none of the cases of Bartsocas-Papas have been genetically worked up in India, but there are few cases which have only been seen postnatally or photographed. This is a classical net picture of a Bartsocas-Papas syndrome, which shows a classical pterygium in the popliteal region, and this leads to a flexed knee. In our case, the knee were extended. So these are some of my references, which shows the features of Bartsocas-Papas and the RIPK4 gene mutation. And so what I did was I made a comparative chart as to Bartsocas-Papas syndrome, lethal pterygium syndrome, and our case, and few findings like a low birth weight, an anti-mongoloid slant, a hypoplastic nose, some pes equinovarus deformity, some pterygium, but the lack of the popliteal pterygium in our case, and hypoplastic genitalia, but the recessive inheritance pattern did not uh, match up as to the genes presenting over there. So we could not conclude on a definitive genotypic phenotypic correlation. And so we asked for further assistance and we asked Dr. Dalal from Hyderabad to help us out in this. And what he has done so far is he has run through our FASTQ data and has asked for a whole genome sequencing of the both the parents and the fetus. And maybe in times to come, we would come up with probably the first case of Bartsocas-Papas syndrome in India. This is our genetic report, which is we have a very good quality of DNA available with us with a value of about 2.07 and about 2820 nanograms of DNA is available with us. So I hope in the coming times, we may come up to a definitive conclusion. Thank you all for very patient here.
Thank you, Dr. Bapna, for that interesting case. Our next speaker is Dr. Venkatesh from Pune. He'll also be presenting a lethal congenital contracture syndrome type 9. Dr. Venkatesh.
Yes, ma'am. Good evening, all. Thank you for giving me opportunity to present such case in this large national level platform. Today's topic of my presentation is a lethal congenital contracture syndrome type 9. Brief case report. 25-year-old female with 18 weeks of pregnancy came for anomaly scan and having normal NT scan, which is reported outside, which a non-consanguineous marriage with unremarkable family history. Obstetric history is a G2, P0, L0, and A1. So in first pregnancy, unexplained pregnancy loss around 9 weeks, and mother denied any exposure to alcohol, teratogenic agents, radiation, or infectious disease in the pregnancy. So in our patient, in right upper image, we can see there is a rocker bottom foot image and similar representative image in abortus fetus. We can see. So in a left lower quadrant, we can see there's a club foot and similar represented image we can see in this abortus. So both of the findings are confirmed on this abortus fetus. So in the cine loop images, we can see one foot is a rocker bottom and another foot is a club foot, and it associated with this diffuse soft tissue paucity and associated with this skeletal muscle atrophy in the both limbs in leg. So similar findings we see in this upper limb. So in upper limb, So it's a continuous flexion deformity of this finger with a diffuse soft tissue and the skeletal muscle atrophy is seen around these both forearms. So patient directly went for this termination of the pregnancy and went for exome. Then this came positive for this pathological variant, which is ADGR G6, which is on location is the exome 4 with homozygous conditions and autosomal recessive in inheritance. So in discussion, so the lethal congenital contracture syndrome is a rare and severe and lethal class of arthrogryposis. So LCCS is a autosomal recessive syndrome. So in comparison with the other distal arthrogryposis, which is a autosomal
Dr. Venkatesh?
We've lost your voice.
hello.
Yes.
So prevalence of this condition is approximately 1 in 25,000. So currently, so there are over 400 genes associated with the arthrogryposis, so it's encapsulating this a wide variety of genes affecting different pathways, including genes are associated with this axon structure, circulatory developments, and the synaptic transmissions. So in our case, so there is the ADGR G6 mutation. So ADGR G6 mutation is nothing, it's the adhesive G protein coupled receptors G6, which is a major constituents in this basement membrane, which is essential for this normal myelination of these axons. So adenosine G protein coupled receptors play critical role in cell to cell and these cell to extracellular matrix interactions, which also plays critical role in the Schwann cell maturation and this mediated myelination in this peripheral nervous system. So in this condition, there are also findings includes the so in LCCS. So there are also agenesis of the limbs and degeneration of this motor neurons, which are characteristics of this lethal congenital contracture syndrome. So these clinical manifestations are accompanied with there is a malformation of these limbs and joints. Also, is a progressive contractures involving these upper limb and lower limbs. Also, skeletal muscle atrophy. So this leads to this continuous flexion and extension limitations of this both upper and lower limbs. So it also associated with this facial dysmorphisms or pulmonary hypoplasia or cerebellar hypoplasia. So up to far there are more than 11 subtypes of this lethal congenital contracture syndromes have been identified. So in our case, it comes to the type 9. Thank you.
Thank you so much. Our next speaker is Dr. Dhaval Patel. He'll be presenting, he's from Gujarat, and he'll be presenting a case of isolated rhabdomyoma.
Hello.
Yes, you're audible.
Okay. So this is the isolated rhabdomyoma in fetus. I'm presenting a case. Okay. 26-year-old second gravida female, non-significant medical history, refer for the second opinion in 27 weeks for the fetal intracardiac mass, FTS not done, RH positive, and non-consanguineous marriage. Sonographical findings are the normal growth parameters on ultrasound, but in echocardiography revealed a intracardiac mass. No family history of genetic disorder, including the tuberous sclerosis. So her imaging findings are there is a single homogeneous focal hyperechoic mass which is located into the right and left ventricle attached to the interventricular septum, and the size is around 2 cm. But the cardiac function is appear normal and fetal neurosonogram is also appear normal. No other abnormality is detected in fetal heart and other systems. So this is the few images is a inflow and outflow of the fetal heart. There is a mass in the located into the right and left ventricle, including with the interventricular septums. These are the few 3D rendering images. And see, this is the in this today clinically we can easily see there is a right and left ventricle in intracardiac mass with interventricular septum, and this inflow and outflow it's not obstructed yet. And her fetal neurosonography was done. There is a no find any tuberoma in brain. So this is the few images of the fetal neurosonogram. It's appear normal. So we advise there, there is a strongly association of the intracardiac rhabdomyoma and with tuberous sclerosis. So genetic counseling was done and amniocentesis offered for the tuberous sclerosis gene mutation and fetal brain MRI also advised. But patient denied for the further investigation and termination of pregnancy was done elsewhere. This is a cine clip of this rhabdomyoma mass in intracardiac, in right and left ventricle. There is a no outflow obstruction there. So what is the rhabdomyoma? It is a rare benign tumor which is arising from the striated muscles due to the sporadic and genetic mutation, most commonly involving in the fetal heart and pediatric cases. Some data suggests that is some maternal and placental hormonal influence during the pregnancy. Prevalence is most common cardiac tumor in fetus in neonates, frequently associated with the tuberous sclerosis, more than 80 to 90% cases. It's an autosomal dominant variant and it is most commonly found out in mid and late gestational, frequently asymptomatic. Large or multiple rhabdomyoma may lead to the complications such as the fetal arrhythmia, obstruction of the blood flow, and hydrofetalis. This is the some differential diagnosis of the fetal cardiac tumor according to the histological types, location, echo characteristic, numbers, and associations. So, what is the diagnostic criteria? The diagnostic criteria is a cardiac rhabdomyoma is detected mostly is a multiply. There is a positive family history of the tuberous sclerosis, pathogenic gene mutations identified by the genetic testing, and fetal CNS find cortical tuberous or subependymal nodules. And postnatal clinical trials are finding in tuberous sclerosis is the seizures, intellectual disability, and cutaneous angiofibroma. In fetuses with the isolated cardiac rhabdomyoma, diagnostic tuberous sclerosis cannot be confirmed without any genetic or additional imaging evidence. So how do we proceed further this case? Careful evaluation of the fetal brain, 4-weekly follow-up of fetus, explain the likelihood of the tuberous sclerosis, family workout, genetic testing or counseling, delivery at tertiary care center, clinical evaluation of baby, ECG and echo postnatally, and postnatal genetical evaluation of this tuberous sclerosis genes. So does tuberous sclerosis will manifest neonates and childhood in case of the isolated rhabdomyoma in fetus like in our case? Of course, yes, there is no any guarantee that isolated rhabdomyoma not associated with the tuberous sclerosis. 15 to 20% of isolated cardiac rhabdomyoma may still eventually be linked with the tuberous sclerosis, even if tuberous sclerosis is not apparent at birth, but the subtle or mild manifestations such as the skin lesions, seizures, and development delay may emerge later in childhood. So there is no additional finding of the tuberous sclerosis. The likelihood postnatal tuberous sclerosis manifestation is low, but not the zero. So ongoing monitoring and still recommended during the early childhood. So what is the management plan prenatally? Close monitoring for arrhythmia and sign of obstruction every 2 to 4 weekly treatment. Consider preterm delivery only if the hemodynamic obstruction causing the hydrops. So prenatal we can start prenatal therapy with anti-arrhythmia, genetic counseling. Suppose patient has any multiple any hemodynamic changes, so we can start the sirolimus or everolimus. Delivery planning, mode of delivery is a vaginal delivery until unless any obstetric indications for the C-sections, and neonatal immediately postnatal evaluation with the fetal echocardiography. So what is about the sirolimus? In isolated cases, sirolimus is a mTOR inhibitors for the isolated fetal cardiac rhabdomyoma. It is still in investigational stage and there is a limited evidence. So isolated fetal rhabdomyoma, they do not require prenatal intervention with the sirolimus because the most of the these tumors is a benign nature and natural they are naturally regress after birth. But in complex cases, it shrinkage the tumor size, so it improves the cardiac function. Postnatal course is a postnatal assessment by the postnatal echocardiography and cardiac MRI. Genetic testing management strategy is expectant management if any hemodynamics compromise or arrhythmias. Follow up every 3 to 6 months in neonatal medical management. If any heart failure or may rarely require some beta blocker or antiarrhythmic drugs, surgical intervention if all adversely affecting the cardiac function. So prognosis rhabdomyoma often regress spontaneously after birth. Isolated rhabdomyoma have excellent prognosis. Associated syndrome like tuberous sclerosis may worsen the prognosis due to the other complications. So why should fetal isolated rhabdomyoma resolve spontaneously after birth? Because they reduce the myocyte proliferation after the birth. Hormonal withdrawal, program cell death due to the apoptosis, improve the postnatal circulation, which increase the oxygenation and independent circulation, which may reduce the vascular demand on the tumor and contribute to its regression, lack of malignant potential. So in the absence of complication, rhabdomyomas are often regress spontaneously in infancy or early childhood. So why should fetal rhabdomyoma is mostly formed in the fetal cardiac ventricles, not in why it should not in atria? So the myocardial predictions that the ventricle contain more myocardial chunk, so more cardiac myocytes than the atria, so making them it is most likely to site of this tumor. Embryologically development, the ventricles undergo the extensive myocyte proliferation and differentiation. So the abnormal myocardial cell proliferation, they naturally localize the cardiac muscles. It is the most active growing site, it is the ventricles. So association with the tuberous sclerosis is the ventricles, they are being the primary contractile chambers and have a more robust muscles development, making them main site of the tuber origin. And of course, the last and not the least is the blood supply and the growth factors. So ventricles receive a rich blood supply, growth factor. Thank you very much.
Thank you so much, Dr. Dhaval. You always tell us why the lesion has happened. Thank you for that information. Our next speaker is Dr. Sri Lakshmi KN from Shimoga, Karnataka. She'll be presenting on Nance-Horan syndrome. Please come on to full screen, Dr. Sri Lakshmi.
Yes, ma'am. Am I audible?
Yes.
Okay. Yeah. Good evening, all of you. Thank you, Society of Fetal Medicine, for a great opportunity. This is my second time that I get to present in the World Defects Day. Nance-Horan syndrome is one of the very rare X-linked dominant disorder. And today I'm not going to present much on the case, but I'm going to present how we should be approaching such rare disorders. It is always very satisfying when we diagnose a single gene disorder, and especially when we can offer a definite prenatal genetic testing at the right time. It is very rewarding as well. So the patient was a newly married couple for about few months of consanguineous marriage, and the girl was very particular that when she came for an NT scan about 12 weeks, so she just opened up herself, telling her mother, her brother, both of them have some ophthalmic disorder. She said that one of the eyes of both her brother and mother are small, and mother has vision problems as well. But her main concern was her brother was had intellectual disability, but mother was had a normal intellectual function. IQ was normal. So she was worried that whether it can inherit to her baby. So I examined both her mother and the younger brother. I could make out this, they are of similar phenotype, but I referred them to ophthalmologist for a detailed phenotype. So what we could see was the affected male had a dense nuclear cataract with a microcornea and intellectual disability, whereas mother had posterior bisutural cataract, small cornea, reduced vision, dental anomalies, but her intellectual function was normal. So when we could record the complete phenotype of the affected patients, and this was the 3-generation family pedigree. So she is the second person in the second generation was the one who was pregnant and was concerned about the inheritance, and her mother her brother and her brother, 3 people were affected. So what I could see that since 2 generations are affected, it should be definitely a dominant condition. But the thing is, they are of a similar phenotype, but the variability in the expression was very much seen. My brother definitely had mental retardation, intellectual disability. So with this concern, I sent for whole exome sequencing of mother. So we got the Nance-Horan syndrome with a OMIM of 302350, which was an X-linked dominant condition and frame shift deletion. So we could offer at the right time by about 16 weeks an amniocentesis, and definite prenatal testing could be offered. Yes, of course, at anomaly scan and even at the interval growth scan, I was looking for the eyeballs and cornea, as well as about the lens as well. But however, we had a molecular diagnosis in our hand, which was negative. So she could continue the pregnancy. So what I could infer from the complete workup of this family was, yes, sorry for the spelling mistake. The whole exome sequencing has made most of the single gene disorders the accurate, affordable, and available. It is time for us to tell that this whole exome sequencing is available, affordable to other specialities. We as obstetricians, radiologists, and pediatricians are very much aware about whole exome sequencing, but it is not the same when come to the other specialties, especially ophthalmology and dermatology, where we have lot of genetic disorders. So it is right time now to make them aware, take them to these diagnoses. So always draw the pedigree so that you analyze the 3-generation history, and take the help of other specialities for accurate phenotyping. Probably if I myself had done this phenotype and had asked for the whole exome sequencing, we might have missed the diagnosis of Nance-Horan syndrome. Since I had taken the help of an ophthalmologist who could completely write the opthal phenotype, the genetic disorder became an accurate, and we could diagnose at the right time. And yes, we should always publish these rare genetic disorders so that we have a good data. And I have published this article in the National Journal as well. So these are the points that I could learn when I diagnosed this Nance-Horan syndrome. And in all subsequent pregnancies, yes, we have offered her definite prenatal testing by chorionic pillar sampling and Sanger sequencing. And yes, although this was a consanguineous marriage, I was not expecting a autosomal recessive disorder, because all 3 generations were affected. So it may be probably a dominant condition. I was sure about that. So even if it is consanguineous marriage, we should not be thinking only of recessive disorders. We should be thinking of other genetic disorders as well. So this variable phenotype was one of the pointers to tell me that yes, it should be some dominant conditions. Probably all these helped the patient, the lab people, to diagnose a rare genetic disorder. So thank you very much for the opportunity. Special thanks to Rima ma'am.
Thank you, Sri Lakshmi. That was indeed an excellent workup, and that's how that phenotype and genotype needs to be
Yes.
correlated. That's the learning that we have to
Yes,
take
this
home.
is the learning curve.
Yes.
And we should involve ophthalmologists and dermatologists. There are so many genetic disorders who have retinitis pigmentosa and so many kinds of congenital cataract, ectodermis, epidermolysis bullosa. All these, we should make them aware that whole exome sequencing is accurate. This is the right time for us to make them aware of this. Thank you
Right.
very much, ma'am.
Thank you.
Yeah.
Thank you, Sri Lakshmi. So our next speaker is Dr. Nisha Suresh. She has a very interesting case of portal sinuses agenesis with extrahepatic portosystemic shunt type 2. She hails from Kochi.
Thank you, ma'am. Good evening, everyone. Thank you so much for giving me this opportunity to present a rare case of portal sinus agenesis with extrahepatic portosystemic shunt type 2, Abernathy type 2. So moving on to my case, she was a 28-year-old gravida to abortion 1 who was referred to a department at 20 weeks in view of portal agenesis. She didn't have any significant medical or surgical or family history. She was a non-consanguineous marriage. Her first trimester scan was normal. Combined test showed low risk. And this is what we could see in the growth. Everything was in the normal range. While we examined her portal system, we found out that we could see the umbilical vein going into the liver, the branches of the left portal vein, the superior, inferior, and the medial portal vein. And usually it curves towards the right, and use of the portal sinus that was missing. The portal sinus was absent. Here we can see the splenic vein, the superior mesenteric vein joins together to form the main portal vein. And the main portal vein usually give rise, we could see the anterior and posterior branches of the right portal vein. But along with that, we could see a shunt between the main portal vein and the inferior vena cava. So there was an extra hepatic portosystemic shunt. Moving to the video, here you can see the branches of the left portal vein, the superior, inferior, and medial branch. The portal sinus was clearly absent. Here you can see the main portal vein and the shunt between the main portal vein and the IVC. So we came to the classification as it is a case of extrahepatic portal systemic shunt, Abernathy type 2. The DV was present, the portal sinus was absent, the main portal vein was seen entering into the right lobe of the liver, giving a collateral branch to the IVC. Amniocentesis was done, and the sample was sent for whole exome sequencing. It came out to be normal. Since she didn't have any other genetic comorbidities, or the genetic test came normal, we advised her to continue the pregnancy. Patient agreed for the same, and this is an ongoing pregnancy, and we are calling back for her for regular follow-up. So what to know the details about umbilical portosystemic shunt? This is a stick of a normal portosystemic shunt, portal system. In this, you can see the umbilical vein entering into the liver. In the left interlobar fissure of the liver, it joins with the left portal vein. You can see the 3 branches of the left portal vein, the superior, inferior, and the middle branches. Here you can see the DV. This is what I told. It normally curves towards the right, away from the stomach. And this is a portal sinus. The main portal vein will come from the left. The main portal vein is formed by the confluence of splenic vein and the superior mesenteric vein. It joins at this portal sinus. And then you can see here the two branches of the anterior and posterior right portal vein. This is a normal portal system shunt. So in Acheron's paper, he has classified umbilical portal venous systemic shunts into 3 different categories: type 1, type 2, type 3A, and 3B. So going to the types of shunts, here you can see this is the type 1 shunt, that is the umbilical venous systemic shunt. Normally the umbilical vein should go into the liver, but here you can see in this the umbilical vein is bypassing that and just draining directly into the heart. So there's a shunt between the umbilical vein and the systemic circulation. The intrahepatic portal system is absent. And in type 2, that is the DVSS, ductus venosus systemic shunt. In this, you can see that the ductus venosus is entering into the systemic circulation. And type 3, it is the intrahepatic portal systemic shunt. In this, you can see there is a shunt between the intrahepatic part of portal vein and the hepatic vein. Most commonly between the medial branch of left portal vein and the middle hepatic vein, there will be a shunt. And lastly, the type 3B. Type 3 can be divided into intrahepatic portal system shunt and EHPSS. In EHPSS, he has classified the types into Abernathy type 1 and Abernathy type 2. Type 1, the intrahepatic portal system will be absent. You can see that the main portal vein is draining directly into the IVC. Either the splenic vein and the main portal vein will be draining separately, or it can join together to form the main portal vein and can drain into the IVC. Whereas in our case, type 2, you can see the intrahepatic portal system may be partially present and the main portal vein will drain into the IVC. So why to learn all this difficult classification system? To know the prognosis. That is important, because if you know the prognosis, we can counsel the parents accordingly. So in type 1, the UVSS, there is intrahepatic portal system is completely absent. So the prognosis is bad. In type 2, the DVSS, it is a type which is commonly associated with aneuploidy. So we have to rule out aneuploidies. And if it is, if there are no aneuploidies, the prognosis is good. And in type 3A, that is an intrahepatic portal system, it is a group that is most commonly associated with FGR. So we have to rule out, we have to monitor the baby for growth. And type 3A, the EHPSS, in our case, the intrahepatic portal system was intact and we did the genetic testing. So we are allowing to continue, we have counseled the parents that we can continue the pregnancy, and post delivery, we'll have to evaluate the baby to assess the size of the shunt, and maybe coiling, or we have to manage the shunt between the systemic circulation. So that is importance of knowing this classification. Thank you.
Thank you so much, Dr. Nisha. Made a very complicated topic very simple. We'll just take a little break for trade partner videos and we will come back with our cases. Okay, so now after this break, we have another interesting case by Dr. Varun Thakur from Pune. He'll be presenting a case of fetal hepatic hemangioendothelioma causing anemia and which required intrauterine transfusion. Dr. Varun Duggal from Pune.
Good evening, everyone. Am I audible, ma'am?
Yes, you're audible. Please carry
And my
on.
slides are also visible?
Yes, please carry on.
Perfect. So at the outset, I'd like to thank Khurana sir, Mohit Shah sir, and Rima ma'am for giving me this opportunity. My case is quite an unusual case of hemangioendothelioma, which required an intrauterine transfusion for fetal anemia. So this was a 30-year-old lady who was a second gravida, had one living issue, was referred to me at growth scan for a prenatally diagnosed Wilms tumor. All the previous scans were done elsewhere, and these were the findings. So whenever we get such a referral, the first thing that we do is we actually confirm if truly there is a lesion or not. And what we can see here is there is a heterogeneous lesion in the left half of the abdomen, pushing the stomach towards the right side, and the stomach appears to be tubular, and the umbilical vein is coursing more from the right side. On color Doppler, the lesion is taking some peripheral vascularity, not significant though, but yes, it is taking the vascularity, and that's the umbilical vein which was coursing more from the right side. So now we know for sure that there is a lesion. I wanted to know what was the origin of the lesion. On subsequent scanning, what I could see was the fat plane between the kidney and the lesion is certainly maintained. So that means it is not a Wilms tumor. And the adrenals are also separate from the lesion. So now we have the lesion which is in the left half of the abdomen, not arising from the kidney or adrenal. So I thought probably it is arising from the left lobe of liver. And then my differentials were either it is a hemangioendothelioma, because that is the most common tumor which will happen to a fetus in this age group, or a hepatoblastoma. After reading further, what I realized was hemangioendothelioma, of course, is a vascular tumor, and it will show vascular redistributions. In our case, we had a celiac artery which was very prominent, and that's a normal celiac artery, just to show that it is a normal caliber, and this is an enlarged celiac artery. And we see a left dilated hepatic vein. So now we know that this lesion is arising from the left lobe of liver. That's why the left hepatic vein is dilated. Hemangioendotheliomas can also cause anemia because of entrapment of the red blood cells. So when I did the MCA PSV, to my surprise, the velocity was 84 centimeters per second, which was corresponding to 1.8 mOps. So certainly the fetus was anemic. I told them that, look, if it's a hemangioendothelioma, these tumors are known to regress on their own over a period of time. So you need not worry after birth. You'll only have to follow up. For now, because the fetus is anemic, I would like to offer you an intrauterine transfusion. So because they had a previous child which was kept in NICU for 3 weeks, they opted for an IUT for this fetus. So we did the IUT. That's the needle going through the placenta into the umbilical vein, and we can see the gush of blood through the umbilical vein. After the IUT, the PSV fell down to 56 centimeters, which was corresponding to 1.18 mom. Few weeks later, because the lady started complaining of reduced fetal movements, the child was delivered, and the pediatrician did alpha fetoprotein. So alpha fetoprotein of this child was more than 2 lakh units at birth. So I was really scared. They called me that, Varun, it's more than 2 lakh units. So then I thought, oh, probably wrongly transfused a hepatoblastoma, because hepatoblastomas will show such type of high alpha fetoprotein levels. So on reading further, I got to know that 5% of hemangioendotheliomas will also show raised alpha fetoprotein. Simultaneously, they also did a CT scan, but CT scan was pretty much typical for hemangioendothelioma, which showed a peripheral enhancement, central low density area, a dilated left hepatic vein, and we see a prominent celiac artery. So CT scan reported it as a hemangioendothelioma. So after a month, they repeated the alpha fetoprotein, and the alpha fetoprotein levels dropped down to 22,000. So from 2 lakhs, it went down to 22,000. So I had my sigh of relief ki, okay, fine, now it is certainly a hemangioendothelioma. So by now, the obstetrician, the pediatric surgeon, and the parents, everybody developed faith in me, and they kept following the child with me for all the subsequent ultrasounds. So in April, the lesion, which was previously 120 cc, measured 93.5 cc. We can also see the dilated left hepatic vein here, because it is draining the entire left lobe of liver. In May, it was 79 cc. In June, it reduced even further to 70 cc. In July, it was 74. It was kind of static. They didn't come in August. Straight away, they came in September when it was 47 cc. In October, it was 33. So you see, it was continuously decreasing in size over a period of 6 months. And now the pediatric surgeon decided to do a LFT, which was absolutely normal. Meanwhile, they also did echo of the child to look for any cardiac overload. That was also normal. But still, the child was put on propranolol and was managed conservatively all throughout. So now the pediatric surgeon decided not to do any further testing, and they sent the child straight away to me after 6 more months. That was on the first birthday in March. And then it was 22.2. It reduced significantly by then. And in October 2024, it completely disappeared. So that was the happy couple with the child. This photo I took with their permission, and that was my case. It was rather a rare case of hepatic hemangioendothelioma, and even rarer that it caused anemia and needed a transfusion. Thank you so very much for the opportunity.
Thank you, Dr. Varun. That was indeed a very interesting case and another rare indication of intrauterine transfusion. Thank you so
Thank you, ma'am.
much. Our next case is by Dr. Dhaval Patel, and he will be presenting a case of isolated absent or fused ribs in fetus.
Is it visible, ma'am?
Yes, you're visible, and you can start. You're audible also. Thank you.
So primary 29-year-old female, non-consanguineous marriage, RH positive, FTA screening done outside, it's normal. Family, medical and surgical history is non-significant. The USG finding is multiple segmentation defects in thoracic and lumbar vertebra in a form of the hemivertebra and the butterfly vertebra. Minimal scoliosis was there. Sixth and ninth rib is missing on the right side of the spine. Fused ribs seen in the level at the level of the 9 to 12th ribs near the posterior and in the right side of the spine. No tether cord seen. Right kidney is minimal smaller in size. So we advise a fetal brain and spine MRI and genetic testing and antenatal pediatric surgeon consultations. But this is the few images, 2D images of the missing ribs and multiple hemivertebra with scoliosis with few ribs are fused. This is the 3D rendering images. This is the spine. This is like zigzag appearances of the spine with multiple hemivertebra and this butterfly shape of the vertebra. PAMC scenes. Right kidney is minimal, smaller it is compared to the left kidney. This is a 4D video clip of the spine and the ribs. So fetal MRIs tell us that there is a correlating with the ultrasound finding multiple segmentation anomalies noted in the thoracolumbar vertebra. However, the no kyphoscoliosis deformity at present and follow-up is required. So after counseling with antenatal pediatric surgeons, patient opted for the termination of this pregnancy. Cord blood sample was taken, but she was not ready for the further genetic evaluation, but we stored the DNA. This is the fetogram. Same finding is corresponding to our ultrasound finding. So what is the ribs, missing ribs? Isolated, absent or fused ribs are very rare congenital anomalies detected during the routine anomaly scans around the 20 weeks of pregnancy. It can occur due to disruption in embryological development of somites, and it is important to differentiate between the isolated versus syndromic cases. So basically, embryologically is a paraxial mesoderm which form the paired somites, and these somites segment and differentiate into the sclerotum and dermatome. This sclerotum gives the vertebra and ribs, and dermatome gives the skin and the muscles. So this is a few embryological images, how the formation of ribs and all. So ribs develop from the sclerotum portion of the somites. Any disruption or failure in the somites segmentation or differentiated, which leads to the absence of ribs and fused ribs, and incomplete segmentation of somites, which is form a hemivertebra during the vertebral body formations. So normally development occur between the 3rd to 5th week of the gestations. So what about the etiology? So genetic cause, somite development defects, some gene mutations are there, some syndromic condition like spondylocostal dysostosis, which I probable diagnosis in our cases, vectoral association, June syndrome, and environmental factors such as some teratogenesis, some drug, and a mechanical factor like oligohydramnios and uterine anomalies. These are the few anatomy pics of the anatomy of the ribs. So why should importance of the rib imaging in the anomaly scans? So fetal rib abnormality can involve the shape, length, number, fracture, and unusual articulation of the ribs. The abnormalities of the ribs can be isolated entity or a part of the genetic conditions. This is the normal appearance of the ribs. At the first trimester, ribs up to the level of the atria. At the second trimester, up to two-thirds of the thorax. And symmetrical of lungs is there. Heart, 1/3 of the thorax is covered. And rounded appearances of the lateral chest will be needed. So the measurement of the ribs in these such cases is very important. And rib is measured in the transverse view of the lateral chest of the fetal chest in the 4-chamber view. So this is the nomograms of the fetal ribs length. So anomalies associated of the anomalies associated with the ribs number are it is mostly isolated. Prognosis is good in the absence of other major abnormalities. Low accuracy on routine ultrasound, and ribs is not counted during the routine our routine scan or in our ISO guidelines. So few skeletal dysplasia associated with the ribs abnormality like thanatophobic dysplasia, short rib polydactyly syndrome, thanatophobic dysplasia, osteogenic imperfect, and achondrogenesis. So prenatal diagnosis by ultrasound by 2D and 3D images, any defect, rib malformation, spine segmentation defects, and associated anomalies, we apply the 3D and detailed evaluation by the detailed evaluation by the fetal MRI. Genetic testing also we should advise. Postnatal cause may probably genetic syndromes, we should be ruled out, chromosomal anomalies, environmental factors, and mechanical factors. Differential diagnosis is always debatable, isolated versus syndromic condition like Klippel-Feil syndrome, golden heart syndrome, Vactral, and spondylocostal dysostosis. So management during the prenatal time is a close monitoring, genetic testing, monitor for the potential lung hypoplasia and thoracic insufficiency, delivery at tertiary care center. Postnatal is a multidisciplinary approach. Surgery may be needed for the severe cases which affect the chest structure and breathing, chest X-ray or CT, and monitor the growth and the respiratory functions. So prognosis depend upon the whether the condition is isolated or syndromic. Isolated we have a minimal impact, but the syndromic cases depend on the which condition or which severe, how the severe condition was there. And the potential challenges are cosmetic concerns, rarely mild restrictive lung disease, long-term outcome depend on the severity of the ribs anomalies, and regular follow-up is essential for the during the childhood. Thank you, ma'am. Thank you very much.
Thank you, Dr. Dhaval, for those wonderful images. Our next speaker is Dr. Devashri Salonke from Pune again. So Pune, we have a lot of speakers from Pune today. She will be taking us through thick and thin, the corpus callosum, where size does matter. Dr. Devashri.
Yes, ma'am. So good evening, everyone. I would like to thank the Society of Fetal Medicine for selecting my case and giving me this opportunity to present on such a large platform. So here I would be presenting a case of the thickest corpus callosum ever reported in literature to my best knowledge. So a 35-year-old female with a gestational age of 20 weeks came in for an anomaly scan. So here in the per-abdominal axial cine, we can see that the CSP appears slightly prominent and the rest of the brain seems to be normal. However, we can see two subtle findings. One was a poorly visualized parieto-occipital fissure, and the lateral fissure, although it makes an obtuse angle, it appears shallow. So we can suspect an evolving malformation of cortical development. Now, on the sagittal section, we can see that the corpus callosum could not be clearly visualized. So hence, we went in for a transvaginal scan in which we can see that the corpus callosum appears grossly thickened in its entire extent, and it appears isoechoic to the brain parenchyma. Also, the echogenic lining above the corpus callosum indicates the pericallosal sulcus. Now, on color Doppler, we can very beautifully see the pericallosal artery, thus confirming that this is the corpus callosum that we are looking at. Now, to my best knowledge, according to an ISWOG article, the thickest corpus callosum which they reported at 22 weeks was 4.2 mm, whereas in our case, it is almost 5 mm at 20 weeks. So we counseled the patient for invasive testing, which she didn't go through, and she continued the pregnancy. And she came to us for a follow-up scan at about 28 weeks. So in this cine, we can see that there is bilateral ventriculomegaly. The size of the ventricles is about 16 to 17 mm. There is a grossly dilated CSP. And the corpus callosum again appears long and thick. Here the diameter is about 7 to 8 mm thick, whereas the normal at this stage it should be about 2 mm is the upper limit. The third and the fourth ventricles were normal. The posterior fossa structures were also normal. The sylvian fissure again is very shallow. The parieto-occipital fissure was not visualized. The convexity sulci are poorly developed for this gestational age. Again, we can see the pericallosal artery here. So these features were suggestive of lissencephaly. Now the patient underwent a fetal MRI. So these are sagittal T2 weighted images again in which we can see ventriculomegaly. The sylvian fissure is poorly developed for the given gestational age. There is paucity of cortical sulci. Now I will just pause at the bookmark Here we can see a thick iso-intense corpus callosum. So it is iso-intense with the rest of the brain parenchyma. Again, these features are suggestive of lissencephaly pachygyria complex. So a 3 kg female baby was delivered normally at full term. And these are the postnatal images. So again, the lateral ventricles and the CSP is grossly dilated, and the corpus callosum measures 9 to 10 mm. Here again, normal for this stage should be 2 to 3 mm. And this is a 3D rendering image showing us a thick corpus callosum. Also, a postnatal MRI was done. So this is a T2 weighted coronal image in which the corpus callosum is grossly thickened. There is a dilatation of the CSP and the lateral ventricles. A broad gyrus with a shallow sulcal space is suggestive of pachygyria with lissencephaly. So now we counsel the patient to undergo a genetic testing, and this is the report. So we can see 5 variations of unknown significance. No pathogenic variant was found. The phenotype on USG may not be clinically related to this genotype. So parenteral testing is necessary to look for these genetic variations in the parents. Now, my take-home message would be, when should we start commenting about the corpus callosum? So the normal development starts at around 12 weeks. And we can see the corpus callosum around 17 to 18 weeks. But in suspicious cases, I think we should not be in a hurry to report it before 20 weeks. As by the new amendment, it allows us termination up to 24 weeks. So we should we can call the patient for a follow-up scan and then comfortably comment on the corpus callosum. Now, what is the importance of doing TVS? So a high frequency probe is very important because it provides a significant better image resolution, especially for allowing detailed visualization, especially for smaller structures like the corpus callosum. And a mid-sagittal section should always be included in your neurosonogram. And lastly, what is the importance of genetic testing? So according to literature, about 25% cases of corpus callosum abnormalities are associated with genetic abnormalities. Hence, genetic testing is a must. According to a few papers, prognosis in the isolated corpus callosum anomalies is normal in about 50 to 60% of the cases. The severity will be variable from mild, moderate to severe with associated congenital anomalies. Now, in our case, since it is associated with genetic variations and lissencephaly pachygyria complex, the prognosis remains uncertain. Currently, the baby presents with failure to thrive and has a difficulty in feeding. So, thank you everyone for your patient listening.
Thank you so much, Devashri. So I think all the speakers have been phenomenal. Two of our speakers could not join due to some urgent family problems. So we apologize on their behalf, but I think everybody was excellent. Mohit sir, you will agree with me that these were phenomenally worked up cases. And we would now request Dr. Aparna Sharma and Dr. Krishna Gopal for their expert comments on these cases, please.
Hi, good evening, everyone. So I think it was like a brilliant collection of cases. We can't say enough. And every time we hear and we listen for, 1.5 hours, when we think, oh my God, there's so much of data, so much of talent here. So I think the few very, very good points which are brought up, like what we saw about the cardiac rhabdomyoma, there's options of therapy which are available, both fetal and neonatal, very well worked up cases. Then, of course, we had the Nance-Horan case where they told how the phenotype is correlated to the genotype. And, we must be aware of how the parents and just connect those dots to get the correct answer. The case on PSS was an absolute visual treat. I think they went back to what the other types are there and what has been described in the, article. And it was really a brilliant thing to watch. And And Dr. Varun, what do we say about hemangioendothelioma? I think when you started talking about it, I said, oh my God, what is this? But I think very nicely presented, and the follow-up is complete. And I really have written also that you must publish this case with immediate effect, immediately in the SFM journal. And
Yes,
I
ma'am.
think this is something that's excellent. Then, of course, there was this thing about the thick CC, and it's brilliant, very nice. And I think it should rather go to the Limca Book of Records also. But I think that's something to think about. But what I, sir, I would like to suggest actually that, we must start something like the SFM Atlas of Fetal Anomalies. And and we call it the living atlas. Like, now you have the living meta-analysis, which is gets updated every time. So it's like an ongoing thing. And you just have like 5 or 6 points. Somebody submits the case along with, what are the findings, what are the associated findings, what are the genetic association, and what are the outcomes. Something like the Palladini textbook, which is like comes once in 4 years. But for the SFM Atlas, it can just keep on getting updated. I think this is so much of knowledge out there that we should not be wasting it. So we must do that with right away. So I think those are some of my thoughts on it, and absolutely brilliant workup and presentation. So congratulations to speakers, and sir, Mohit, Rima. I think this whole thing has been wonderful. Thank you very much.
I think it's Sir's vision that everybody should be together and everybody should be presenting. We should all thank Khurana sir for his vision that he's always had.
Thank you. That's very kind indeed. Let's get Krishna's inputs as well, and then we go on. Yeah.
That was excellent presentation, simply mesmerized. And each of these cases were totally walked up. And I totally agree with Dr. Aparna's view that we should have an atlas of this kind. And if we don't publish it in 4 years, at least we can publish it as a section in our journal. Because that is a true treat to the eyes. Varun case was excellent, and each of other cases were also so excellent. We have learned so much from it, and we are looking forward for this kind of webinars in the future. And congratulations, Mohit, Rima, and of course the master behind all this, sir, for this visual treat. Thank you.
Thank you, experts, for your wonderful comments. And now it's for Khurana sir.
Thank you. Pardon me for my voice, but it seems to have disappeared suddenly this evening. I will try and convey what I have to. We don't have any questions in the chat box, which is so surprising. But on the other hand, it's not surprising, because what we see here today is that every case has been worked up completely. I don't think we can talk about cases like this in the developed world. And for us, in the so-called developing world, we can be indeed proud that we have reached this level where no case is formidable anymore. And if we make the effort, we seem to be getting results all the way. If a pedigree needs to be drawn up, we draw it up. We should draw it up for everyone, of course. If we need genetics, it's available. If we need knowledge, it's available. If we need a procedure, it's available. And I don't think any country in the world can boast of this. And I congratulate the entire family of the Society of Fetal Medicine for having got together to make all this come true. And to be able to actually showcase this on the Birth Defect Day is really something that is a matter to be extremely proud of. And then we have this excellent suggestion. In the journal, of course, we stuck with peer reviews. But if we have an atlas, like Dr. Aparna has mentioned, then we can go right ahead, a live atlas of malformations. And I would invite volunteers who can put this together, and then we can coordinate this. And it's really an excellent idea. We are looking forward to many more presentations by our young people, and some more ideas by the not so young. And we do hope to put webinars together for the very young, the not so young, the not so very young, and the seniors. And we so look forward to sharing all this knowledge. congratulate ourselves once again on a great occasion like this. And importantly, it keeps up what we have precious at the Society of Fetal Medicine, which is every journey matters. For the fetus that is going from ovum to embryo to fetus to neonate, I think if we can help them along the way like this and make sure that they get an optimal outcome, it's really going to be worth it for all of us. And in a compromised environment like ours, both economically as well as access to good medical care, I think that has already become a thing of the past, because we put in our efforts, we put in our lives into this, we put in blood, sweat, and tears, and it seems to have paid off. And thank you very much for such a brilliant evening. I also want to put on record how nicely Colonel Rima has put the mentoring together, and we haven't had any glitches and hitches. Truly very, very nice. And thank you, Mohit, for always spearheading this for us. It's always great to have you there. Thank you very much indeed.
This has been the most phenomenal webinar, sir. The cases that have been shared are truly amazing. And I agree with Aparna's point. We can make a rare case registry for something like a reference book. It will be wonderful. Maybe virtual, but we can explore ideas. Thank you, Aparna, for this. And thanks, Dr. Rima. This was phenomenal. Thank you, participants. You've all been great. Truly great. Keep up the good work. Let's have more cases from you. Now, this should build up momentum. We should have cases from all over India. Thank you so much. See you all soon. Good night.
Thank you. Good night.
Thank you. Good night.
Good night.